Okay, so let's get started. My name is Lisette Fowler, and I'd like to welcome everyone to the Public Health PBRN monthly virtual meeting for September. This month, we're going to have our Research in Progress presentation by the Ohio Public Health Practice-Based Research Network, Dr. Scott Frank from Case Western Reserve University. Dr. Frank is the founding director of the Masters of Public Health program at Case Western Reserve University School of Medicine. And in addition to his academic role, Dr. Frank serves as Director of Health for the City of Shaker Heights. He is the Principal Investigator for the Ohio Research Association for Public Health Improvement, or RAFI, which is the home of the Ohio Public Health Practice-Based Research Network. And today, Scott's going to discuss findings from the Ohio PBRN Quick Strike study on community health assessment, community health improvement planning, and community health needs assessment. So I'll turn it over to Dr. Frank.
Hi, everybody. This is Scott Frank. I'm presuming you can hear me all right?
Yes, you're coming through pretty clearly.
Great. Thanks, Lizette. We do have two projects going on right now. One is the DAX project, and the other, our Community Health Assessment Quick Strike project. And we've chosen to present on the latter of those two projects simply because we're a little further in our data gathering and analysis for that project. And it is a project that is turning out to be a very rich set of data that we're looking forward to completing and having much more detailed analysis of. I'd like to just give some quick acknowledgments to the Johnson Foundation and their Quick Strike funding, the National Coordinating Committee, RAFI members. The Health Policy Institute of Ohio is our partner on this Quick Strike grant. And I'll mention them a bit later as well. And also thanks to the Wisconsin Public Health PBRN, who developed a chip quality measurement tool that stood as the basis or the foundation from which we built the instrument in this current study. I'm quickly going to go through the specific aims for this Quick Strike grant to investigate the process, structure, and outcome of CHA, CHIPs, and CHINAs in Ohio local health departments and hospitals. To spend just a minute, community health assessment is something that's been required in Ohio health departments for many years, with community health improvement planning being a growth forward on that, with much more structure related to it, and moving beyond assessment to prioritization, implementation, and evaluation. It is that unique part of the chip that we're most interested in, that prioritization, implementation, and evaluation. And as the Wisconsin people have noted in previous studies that they've presented on, that's the hardest part to get information on. The assessment part has a lot more completion to it than the action planning, implementation, or evaluation of the impact of these community assessments or improvement plans. Most of you know that the jargon used for community health needs assessment fits with the hospital community benefit requirement that first was a requirement by the IRS and then was mainstreamed into the ACA. It still works through the IRS, but the rules for it are now defined and described in the Affordable Care Act. The general finding is that coming into this study is that the health departments and hospitals have only overlapped in our Venn diagram of interaction around community assessment to a minor degree in most cases, with some notable exceptions of best practices where health departments and hospitals have worked closely together. This project is intended to look at the extent of interaction between local health departments and hospitals and come up with some best practice recommendations and policy recommendations based on the findings of this study. The second aim focuses on the priorities. I don't believe we have anybody from, maybe we do. The Wisconsin tool really didn't get into what the priorities were that were identified by the chips in Wisconsin, and they didn't get into interaction with the hospital community health needs assessment or community benefit. And so those are differences in what we're doing that sort of define this particular study. Today I'll be focusing on the priorities and some preliminary information about the collaboration between hospital systems and local health departments. I will be presenting only the health department data today. Our partners are in a parallel stage of data abstraction for the hospital CHINAs, but I don't yet have their data to integrate with ours. So I'll be sharing information about the health department, and as I do, I think you'll get a really good sense of how valuable it will be when we fill in the table to include how the hospital community health needs assessments, the CHINAs as we call them, are similar and differ from the public health community assessments or improvement planning. We are seeking to compare both between these groups, hospitals and local health departments, and we'll also be comparing within the groups, looking at structural impact of the hospital and local health department on variation in both process and priorities identified in this process. So as I mentioned, we'll be focusing on specific aims 2 and 3. I'll comment a bit on instrument development, but won't get into depth about it today. I will just share that the Wisconsin Chip Quality Measurement Tool had 45 items. We have used the same domains identified in the Wisconsin tool, but we've shifted the emphasis to include the CHINA, as I mentioned before, looking at the comparison between local health departments and hospital-based processes and outcomes, but also within groups as well. Emphasis on action plan implementation and evaluation also had us doing additional items. So the original Wisconsin version was 45 items. Our expanded version is 71 items. We have different but parallel instruments for the local health departments and for the hospitals. The 71 items that we have includes all of the Wisconsin items, adding additional items as I've described. Some of the items do seek greater specificity regarding process, and we've stepped this through in a crosswalk that allows the comparison of how the community health assessments are conducted by hospitals versus local health departments, and what priorities are identified by these different groups. So the current status of our study is that we have currently completed a review of 84 of the 125 local health departments, and about 60 of the hospitals is the latest information that I had there. We're presenting today a preliminary descriptive analysis based on the local health departments we've found so far. You can see on this slide a description of when the CHAs or CHIPs were initiated, with the greatest majority of them coming between 2011 and 2013. There were only 2 CHAs and 4 CHIPs among the health departments that I'll be presenting on today that were not available online, though I must say that it took us some substantial effort to find some of them online, even when they were there, even having a grasp of how we should be looking for it. We still had trouble finding some of them. So this is a description of the health departments that we've analyzed, and we have 17 city health departments, making up about 34. So this particular profile of the health departments, we have complete health department profile data on 50 of the health departments. We're still building out that, but of those, and those 50 are among the set that we're looking at today. About 34% city health departments, 54% county, and 12% combined. Jurisdictional size, 32% of the health departments that we've analyzed to date are less than, or serve jurisdictions less than 25,000. And you can see that 66% of the health departments that we've analyzed are less than 50,000 in jurisdictions served. This is actually quite reflective of the whole sample. About 60% of Ohio local health departments serve jurisdictions of 50,000 or less. You can also see part of the issue that we deal with in public health systems and services research as you look at the range on these. The smallest of the jurisdictions we've analyzed is 6,400, and the largest is 525,000. Similarly, with the budget, we go all the way from the smallest budget that we've seen of 25,000 to the largest budget among our sample of 41 million. So you can see the distribution of those budgets across the different health departments. Again, we go from a range, the smallest of our health departments reports 1.3 FTE, and the largest in our sample, 422 FTE employed. And to me, the ranges are almost more interesting than the distribution of our sample, which also does demonstrate that we are looking at a broad cross-section of the Ohio sample. We do anticipate, to date, we have identified 120 out of the 125 local health departments in Ohio, and gotten support from those health departments to do our data abstractions, so we've got more to come. Starting to talk about some of the results now. One of the items that was used in this quality assessment tool was asking how the priorities were chosen, whether they were selected using specific criteria or whether criteria might have been present, but that was not clearly identified in their CHIP-CHA document. A relatively small portion did not set priorities. This would be sort of how we define whether we consider the document from the health department to be a CHA or a CHIP. CHA, by our definition, would not include progression to priorities, and CHIPs do at least plan on priorities, whether or not they've reached the stage yet at which those priorities have been set. So 82% did specify health priorities among the documents that we've reviewed. And we've categorized the priorities into health conditions, health behaviors. These would include individual and family risk and protective factors, community conditions affecting health, health systems, conditions affecting health, and other. The numbers that you see there are the number of times they were listed as priorities across the different health departments that we've abstracted. You can again begin to see that the health behavior category is near 41% for our local health departments, I would expect there to be a pretty substantial difference with health conditions being more likely to be addressed by hospital systems, health systems more likely to be addressed by hospital systems, and the health behaviors and community conditions more likely to be addressed by local health departments. So we're anticipating that. And as we've talked with our partners, we're quite sure that that's what we'll be seeing. But the extent of the difference, we'll need to wait until we get our final data to comment on. It, I think, is affirming to see the extent to which priorities include the health behaviors and community conditions. And we'll get into specifics on that right now. So you have a sense of both how we've counted these and what is included in what we've described in these different categories. So the health conditions include heart disease, diabetes, asthma, COPD, obesity, cancer, infectious disease, infant mortality, oral health, substance abuse, mental health, and under immunization. You can see here that among these health conditions, obesity is by far the number one issue that local health departments state that they're addressing. My bet is that that's very high for hospitals as well, but that they may be more engaged in the heart disease, diabetes, asthma kind of cancer issues than the local health departments. It's also interesting to note that substance abuse and mental health are the second and third most acknowledged priorities among the local health departments in this of priorities. And they're very close to each other and substantially higher than the other health conditions that are listed here. These are the health behaviors that were identified, and you can see the much higher proportion of CHIPS or CHIPS will say that included these as priorities with physical activity and nutrition, of course, relating to obesity, but the nutrition, for example, exceeds both the stated priority of obesity and the stated priority of physical activity. It is absolutely possible that one priority might identify obesity, physical activity, and nutrition all as part of that priority, and that would be abstracted in the same way from hospitals and from local health departments. The substance use, mental health come through here. Youth development doesn't get addressed on the health conditions list, but probably fits very closely with the substance abuse, particularly substance abuse prevention, since most substance abuse prevention takes a youth development approach and uses schools as a place to address those issues. A smaller number involved in sexual, reproductive health, injury protection, or family violence. These are the issues that we've listed for community conditions affecting health, and you can see here that fitting with the theme of everybody's looking at obesity, the food environment is the top of the community conditions. The built environment and the active living environment are not far behind, and a high priority placed on community partnership by almost a third of the CHIPs that we examined. I will say personally it's a bit of a disappointment to see only about 15% of our current sample specifically addressing social determinants of health or health equity. Health systems issues that are addressed in these community health improvement plans are listed here, and you can see that the top involves access to medical care. Preliminary reports from our HPIO partners are that access to medical care is the top priority identified by hospitals over all of these different domains as well. Access to behavioral health, very high on the public health agenda as well, and under insurance, which of course overlaps with access to medical care, is higher than the others, workforce development, and then the others come in at lower levels. The other category we haven't had a chance to take a look at yet, and we may be reassigning some of those that are currently in the other category to our existing categories, but we're not at that stage of our analytic process yet. So we've asked a number of questions about collaboration. Nearly 40% of the CHIPs, CHAs, or CHINAs that we've examined so far have been conducted cross-jurisdictionally. So more than one health department has been involved in the leadership and process of conducting these CHAs and CHIPs. 82% had at least one hospital involved, though that doesn't really get at the depth of that hospital involvement. We do have questions that we'll be looking at under the microscope to get a sense of how involved hospitals were in the CHIPs and how involved local health departments were in the CHINAs. That is still to come. At least one other sector was involved in nearly 90% of the CHIPs that we've examined, and by far most of the CHIPs that we've examined have had 4 or more sectors involved. That's the highest level that we do the assessment at. Hospital involvement does extend to prioritization and implementation 84% of the time, which I think does imply a bit greater depth, that they sort of stick with the project past the assessment stage and into the prioritization and implementation stages. And at least one other sector was involved in prioritization almost 92% of the time. This table looks at how information was gathered from external stakeholders. Nearly 90% of the CHIPs that we've examined did conduct original surveys. More than a quarter conducted hall meetings or town hall meetings or community forums. And focus groups were somewhat less frequently used, but were used by a number of we actually have a much longer list of different sources of input from the stakeholders, but need to do a bit more clustering, I'd say, in order to clearly list some of the others. The number of different types of data sources was counted as not having any not specifying any source categories as clearly specifying only one up to 4 or more source categories, and you can see that by far the majority had 4 or more source categories for data that they used in the process of their chip. The next slide describes the extent to which the chips were using formal models in order to conduct their process, and the extent to which the chips were acknowledging that the state of Ohio has gone through a similar process, a state health improvement plan, and sought to mesh their chip, their local chip with the state chip, and whether they noted national efforts to identify health priorities, and we have a list of different sources of national health priorities that our abstractors have looked for, including, for example, the National Prevention Strategy and others. The groups, the health departments have done a pretty good job, perhaps, of identifying, of using formal models and making it clear the model that they were using within the CHIP process, and have paid more attention to national health priorities than to state health priorities. This, of course, doesn't mean that they haven't paid any attention to it, but their documents don't reflect that attentiveness. So that's the information that I have to share in today's presentation. I'll just, there was one other thought that came into my mind and then flew out. So I'm just going to stop there and open the floor to thoughts or questions.
Thank you very much for that presentation, Scott. I did want to let you know, I don't know if we're having network issues or bandwidth issues, but I have received a couple of emails from folks who can obviously dial in since that's just a phone line, but we're having trouble accessing the actual Adobe room. So I quickly sent out the slides, and so you do have a couple folks that are listening in on the phone but don't appear here in the participant list. So at this point, please go ahead and I'll open the floor to questions, and if you are having trouble, you can't hear, you can use the chat box.
While you all are thinking of questions, I will just make a couple more comments about our process. So here at RAPI, we have primarily actually four abstractors who've been working on document abstraction, and we have done inter-rater reliability testing. We've changed some items, how they're scored based on some of that inter-rater reliability testing. And the same process has gone on at the Health Policy Institute of Ohio, where they have at least 3 interns who've been working on the abstractions with experts reviewing the results of these abstractions and also comparing the reliability between the different abstractors. I'll also say, I didn't say and should have, that part of this study and process will be to identify a subset of 8 local health departments that have conducted CHIPs, and we will be identifying 4 with high scores in the quality measurement tool and 4 with lower scores in the quality measurement tool, and doing in-depth interviews with them regarding their CHIP process. Finally, we also do intend, as was done in Wisconsin, when we have completed the quality measurement tool for all of the health departments, to distribute that to the health directors in those departments and ask them to comment on their perception of the accuracy of the assessment process that we have completed.
Thank you for that. Any questions?
Scott, this is Chris Malin asking this question. Going to the collaboration slide, number 17, except for the cross-jurisdictional collaboration piece, most of those percentages are very high. And, one might conclude that collaboration is a very consistent activity that's going on between hospitals and local health departments. Were you able, though, to explore that any further and try to identify models where collaboration was exemplary and perhaps just sort of a token collaboration? Wouldn't seem as if the measures you've presented here would get at that, and therefore understanding the variation in collaboration might be challenging.
Yes, that's very much part of what we built into the instrument. So as I mentioned, this is a first pass. You can see we're not presenting on 71 different variables here, but our experience is actually that most of the hospital involvement with local health departments and local health department involvement in CHNAs is more superficial in nature. So we have several different approaches to measuring that depth. One of the keys that we're trying to get a sense of is whether the involvement of hospitals in the CHIPS includes decision makers or really frontline hospital personnel who are concerned about public health but have no decision-making capacity or ability to commit resources in the process. So that's the kind of thing that we're looking at to try to get a greater level of depth. One of the functional things that we're looking at, most of the CHIPS identify steering committees, which represents the leadership group for the process. So looking at whether hospital personnel are identified on the steering committee is another way that we'll be getting a sense of of how superficial or committed the involvement might be. Finally, our interview, our semi-structured interview that we'll be doing with the 8 health departments will really 8 health departments and 8 hospitals. So we'll be examining from each end and getting at this issue of how involved the hospitals and health departments are in each other's process, or whether they're considered to be a joint process. We'll have a much better sense of that moving over. We already have clearly been able to identify some best practice kind of CHIPS, CHNA collaborations as we've gone through, and we'll be looking to highlight those in our final report as well.
Oh, great, thank you.
Excellent. Any other questions? Okay, well, thank you very much again, Dr. Frank, for that presentation. We look forward to seeing how these pan out and looking forward to that final report. Okay, so as you know, most of our team is out today. They're scattered to the winds. So we'll probably have a very short call today. I have only a few updates to remind you. First of all, the PBRN research updates. As some of you who were on the directive kickoff webinar, which we held just earlier this week, we are going to be phasing together the IMPROVE, the DAX, the directive, and the FAST teams into one team to hold coordinated calls. These will occur, and I think we have them scheduled here. This is almost the fourth Thursday of each month, but it's not quite. So please go ahead and write these down in your calendars for Thursday, September 25th, Thursday, October 30th, and Thursday, December 4th from 1 to 2:30. As you know, this is an iterative process, and these awards do really build on each other. So we felt that, even if you are not a directive grantee, if you worked on an IMPROVE project or on a DAX project, you have something to contribute to this conversation. And so we would really highly encourage all of these grantees to please participate in these coordination calls. In addition, I know I'm still waiting to receive the team rosters from the directive awardees. So as soon as I get those, I'll be able to send out invitations to all of these grantees for these calls. So please go ahead and send those to me. Any questions about these coordination calls? Okay, now moving on to dissemination opportunities. As you know, APHA is coming up very, very quickly, November 15th through 19th in New Orleans. And I did want to remind you that we are going to hold an IMPROVE and DAX panel at APHA, and that is on Tuesday, November 18th, 10:30 to 12. I don't have the room number with me right now, but I will send that information once we send out all our PBRN meetings for that meeting. So please, if you are going to be at APHA, it would be great for you to go see this presentation. And that follows the next reminder. If you are presenting at APHA, we need to have that information by tomorrow, Friday 19th, by 5 p.m. As you know, we like to create a brochure with all of our PBRN presentations at these meetings. It's something that the foundation wants to see, and it's something that helps you as networks to follow along with what all the other networks are doing. So I would appreciate that information by tomorrow. Another dissemination opportunity is the 7th Annual Conference on the Science of Dissemination and Implementation in Health. This is a joint conference with Academy Health and NIH, which is going to be held in Bethesda, Maryland on December 8th and 9th. If you want any information about this, please do email me. I believe that, I'm not sure if the submission process is closed for that or not, but if you are presenting, I would also like to know that information. And then the final dissemination opportunity is we'd like to provide you with an update on our upcoming Frontiers and AJPH partnership. And Anne, if you're on the line, would you like to provide some more information about that?
Sure. Hi. We have been working with the American Journal of Public Health on including abstracts from Frontiers articles in the AJPH online issue. And this partnership is about to launch. It'll be live by December at the latest, perhaps in November. We're working on production issues now, but the way the process will work is that as each Frontier issue is published, AJPH editors will review it, review the abstracts, and the ones that they feel are appropriate will be published in the AJPH online issue and as individual articles rather than a group of Frontiers articles. And those abstracts will have individual titles in the AJPH table of contents. From that point, if someone is able to review the abstract and wants to see the full article, it'll link back to the Frontiers website. So this is a process we've been working on this year. The first issue will include articles published in Frontiers issues in 2014, and there are actually 3 issues that were published this year so far, and the vast majority of those will be included in the launch, which will be in November, December. In addition to that, we have some production going on for the special supplement to AJPH on advances in PHSSR, and that is scheduled for the spring of 2015. Many of you have submitted articles, and some of the authors, somewhere around 15 articles, have been accepted for the issue. The remainder are out for review, and we're working towards having printed copies available for the Keeneland conference. So there's been a really great number of submissions. The issue itself will have about 25 articles, and based on having 15 accepted so far, we're in good shape for that. So AGBH was very pleased with the submissions and the degree of interest and the quality of the manuscripts. So are there any questions?
Thank you so much for that update, Anne.
Oh, sure.
Okay. I'd like to discuss a couple of research opportunities. The first is the collaboration with JPAL on pragmatic randomized controlled trials in public health settings. If you remember, this is something that Dr. Mace discussed both at the grantee workshop last month, for those of you who were there, and then also at our last virtual meeting. The Abdul Latif Jameel Poverty Action Lab, or JPAL, was established about 10 years ago as a research center at the economics department at MIT. And over the last 10 years, they've provided 150 researchers with funds to conduct over almost 500 randomized controlled trials in various countries to test hypotheses on subjects ranging from education to agriculture, microfinance, malaria prevention. And, you know, they've now turned their attention to the work that we're doing at our PBRNs. And so we're very excited about this opportunity. Please let us know if you're interested. Send us an email. We do have the Kentucky PBRN actually conducted a randomized controlled trial with their QI study of cultural linguistic competency of, I guess this was last year, and so they're writing up some information about that, and we're really excited to see that. But do go ahead and email us with any of your suggestions. The other research opportunity is an opportunity for PBRNs to collaborate with the prevention research centers. This is something that is coming down straight from the CDC. They're sort of pushing for this PRC-PBRN collaboration. We will actually be presenting, this National Coordinating Center will be presenting at the November PRC National Meeting. So I would suggest that you take a look at the CDC Prevention Research Center site that shows where the 26 newly funded centers are located. We're in the process of doing a crosswalk between the PRC sites and the PBRN sites to see if there's where there's overlap and potential opportunities for collaboration. But it would be great if you guys also take the lead on that. If there is a PRC right down the street from you, it would be a good opportunity for some potential collaboration. And last of all, I want to talk a little bit about the website update. We are actually right now in a soft launch period until October 1st, 2014. I believe that all of you should have received an email from Kara Richardson. She sent you the construction URL. So this is the link that you see here with www.uky.edu/public health systems. And this will take you to the current new site. It is live, but unless you have this link, you can't see it. So for right now, if you just put in publichealthsystems.org, you're still going to the old site. But for those of you who have this link, you can see what the new site is like. Remember that it is a work in progress, but we would highly, highly encourage you to take a look at it, send us all your comments, suggestions, corrections. And Kara specifically sent this to the PBRN leaders, asking them to look at their specific site. Each network has their own site, and we have everything up there from all your products, information about your current leadership, a brief description of your work and your network itself. And so we need you to review all of that information. If there are any changes or if there's anything that is up there that you do not want up there for public consumption, please let us know by Friday, September 26th. Again, on October 1st, we will officially launch the site, so anyone who types in the old publichealthsystems.org site will be redirected to this new site. So we really want to give you this time between now and then to please review the website and let us know what changes you think need to be made. Are there any questions about the website? Okay, great. We know that that's been a long time coming, and we're very, very excited about it. We hope that you will agree that it's set up in a much better way to highlight all of the great work that you've been doing. Last of all, I would like to announce the next monthly virtual meeting for October, and the presenter will be the New Jersey PBRN. And then after that, we just have 2 more months until the end of the year, and beginning, well, that should say 2015. So beginning in 2015, we will combine the research in progress presentations with the larger PHSSR grantee research in progress presentation. So what this will do is it'll open up the audience. There'll be a much larger audience for your work, and so we really look forward to that. There might not be the opportunity to present as often, but and we will also have to expand it to more than the third Thursday of the month. So the schedules might change slightly, but we think this will be a good combination. It'll, again, open up your work to a larger audience, the larger PHSSR audience, so we think that will be very helpful. Are there any questions? All right. Well, again, thank you very much. This was, you have 40 more minutes in your day, so I hope that you found this meeting useful today, and please do not hesitate to contact us with any questions. We look forward to receiving the information on your presentations coming up at these national meetings and your feedback on the website. Thank you very much, and have a great day.